Oh, hey, Chris.
Hey Chuck, how are you?
I am warm and toasty. How are you?
I'm also warm and toasty until I have to go out later and shovel my way out of Snowmageddon.
I know St. Louis is not used to this much snow.
I did go out earlier just to see how much snow, and it looked like 8 inches, at least in my neck of the woods.
Yeah, so it is Sunday the 25th. I think we are not alone in St. Louis with this winter storm, and I think many places got hit worse. Chicago, I was talking to a friend this morning, got hit far less than we did, which is interesting, and they handle it better too. So we have an interesting couple of days ahead of us.
Yes, we do. Let's just hope the snow doesn't turn into ice. And I know that in the southeast, there's a lot of folks worry about ice there, and less snow, and then obviously I think ice is much more problematic.
Yeah, being a Southern boy, we used to get, a dusting a year, but if you got the ice, it was crippling to everything. And I did see that. There's ice expected or has already happened.
There are a lot of people in our department that are not originally from St. Louis. So I was talking with one of our partners and former fellows, David Wright, yesterday. And I was like, hey, what you doing? He's like, I just got done salting my driveway. I was like, oh, really? Like you salt beforehand or after? I was like, I never know because like I always feel like it doesn't do much and I end up shoveling away all the salt. He's like, well, I saw my neighbors doing it. And he's from Southern California. So he's like, I figured I should do it too. And then I never know how much or how when to start shoveling. Like right now, there's expected to be another probably 3 hours of light snow. Do I just get a jump on it now, knowing there's still going to be some? Or do I just wait until it's all done and then just go after it? Because I really do love the look of a pristinely shoveled driveway. I know that may not surprise you, but I hate to seeing then more come down.
Yeah, it's funny. My stress is not the driveway. It's giving a path to our front door. And it's also our sidewalks because they're so well traveled. I feel badly if we don't at least try to make them better. And it is funny. The last time we talked about snow, we did get some listener feedback giving us advice.
Yes, we did. Yes, we did. So I look forward to more of that. But today's episode, we're going to discuss some common surgeries that may take a left turn, so to say. I don't know how to better describe it. And then just getting yourself out of some issues. And then I think maybe we could talk about some of your recent academic trips.
Well, hopefully we would include yours in there as well. Yeah, happy to do it. Maybe we'll start by thanking our sponsors. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/slash the upper hand.
So I was, just to get this out of the way, so to speak, I was in Philadelphia and was privileged to be a guest speaker at a lectureship in honor of a senior resident who passed away many years ago. But it's quite a thing and really a nice thing to for the school and for the family to have done for Leo Leon. And it was a great opportunity for me to visit and really see all the good things that are happening at University of Pennsylvania, meet the people, meet the new chair, meet our own Andrew Sobel, who's the residency director and is doing great things. So great trip. Always fun to see different programs.
Excellent. So can you tell us a little bit about your presentations just at a high level?
Yeah, for sure. I'm sort of, I don't like to have to give the same talks over and over, and I try not to. But I've sort of hit on two or three that seem to work. I gave a talk about ulnar wrist and TFCC. That was sort of the technical talk. That was really just to the residents and fellows. The initial grand rounds to the larger department was about impact and how we think about our impact and the books that have resonated with me and it was fun. And what makes it really fun is when the audience and the senior professors and those with even more experience with me than me, because it's a little awkward giving a talk about impact, but when they weigh in, it was great. It was great.
That is exciting. I can't wait for that talk to be delivered to us here locally at WashU.
It is funny, right? Because we don't usually do that. Like we all go out there and give talks and don't share that locally.
Yeah, no, well, I mean, I think many of us have situations where we've gone and done visiting professorships, and then we're like, probably should give this talk at home at some point. So maybe you know a few people who can get you on the schedule.
I'm in a busy stretch of travel a lot. Like I've always said, one a month is fine. More than that is too much, and I'm way over that right now. What about you? What's your travel schedule looking like?
Oh, I don't have a whole lot going on right now, which is very nice. I spent last weekend in Madison, Wisconsin for my son's hockey tournament, which was frigid, which was great training for this current weather situation. But talk about a city that knows how to handle cold weather. But yeah, no recent academic trips because I was there in Madison. I wasn't able to make it to the triple meeting. So I'm sad to have missed the ASPN, but happy to have had those core memories with my son of trekking around Madison looking for hockey card shops and, playing some hockey.
Madison's a great place, even in the frigid weather. Interestingly, they canceled class, I believe, on Friday, which never happens at the university level. My daughter's not there this semester. She's abroad, but that doesn't happen.
Was the weather that bad?
Apparently, it was far sub-zero. So yes, the weather was that bad.
I woke up on the last day of the trip and the feels like temperature was minus 26. And I said, Filipino American boy from Florida, this is not in my blood at all.
Look, I'm Alabama through and through, and this is not in my blood either. We share that heritage. I'm sorry about your hurricanes.
We should not go into this because there are probably people listening from Indiana University who has apparently the largest alumni base in the entire country. But uh, nobody expected us to be there. I'm happy we're nobody expected Indiana to be there either. But congratulations to them. So
Yeah,
we should get into our episode
let's do it.
before we lose our audience just by catching up. So you had the idea to go through a couple of cases that seem every surgery there's no easy surgery, as one of our partners like to say. There's simple surgeries, there's straightforward surgeries, but surgery is still surgery. So are there any particular cases that you wanted to discuss?
Yeah, what I share often is that our field, we are very lucky to do what we do. And I feel strongly about that. People talk about, oh, what's the future of medicine? We're lucky. Like we have a great field, orthopedic surgery, hand surgery, amazing. But it's humbling. And there, as you just said so nicely, there are things that can go awry, no matter how careful, how precise, how good you are. So let's start with the simplest surgery, and I put that in quotes, the simplest surgery there is, trigger finger release. Forever people say, "Oh, this should be 100% success rate with trigger release." Well, that's of course just not true, and there's been a few papers that have come out recently about that. But I had a patient, and not too distantly, where we did, and he's a patient I've operated on for trigger fingers and other things, and thankfully we have a lot of trust built up. And I did triggers on each side under local anesthesia, and he demonstrated full motion with no triggering in the OR for procedure one.
Mm-hmm.
Comes back to the
See where this is
office.
going.
Yes, comes back to the office, and one side was clearly triggering, and the other side he felt a little hitch, as he called it. We talked about options and went back to the operating room. And I
Is
guess
this
I would.
post-op visit number one?
He called before post-op visit
Oh
number one.
boy. Wow. Okay.
Yeah. And I'll put it there. So now and I said, be patient, it'll be fine. And it wasn't the usual, you always also hear complaints about people with longstanding trigger where they can't get that PIP completely straight. And that's a whole nother thing. But he had recurrent triggering and he remembered in the OR there was nothing, felt great. So, how do you counsel that patient? What do you offer them before considering a second surgery?
Yeah, I mean, you mentioned kind of the PIP thing, which I think is important for counseling. The other thing that patients typically come up with is just soreness at the incision. So those are two common things that typically either the PIP thing is not really going to get better and the soreness will improve with time. I probably at this point would have offered him a steroid shot just to see if that would quiet it down because I think the risk of that is pretty low.
Completely agree. And I usually don't do that at the 2 week mark. If I need to, it's more at the 6 or 8 or 10 week mark. And we discussed it, and I offered a steroid injection. He said, no, thank you. Just one of those patients who hadn't had good results and always seemed to, temporary short-term improvement and just didn't think it was worth it. He wanted a more definitive answer.
It's so interesting the patients that come in with bad steroid injection experiences, even at other locations, like subacromial steroid shot didn't help them. So they're like, I don't want a steroid shot for my trigger finger. I'm like, well, the other option is like just watching it or going to surgery. And they're like, yeah, let's go to surgery. I was like, okay. Just not what I personally would do. And I don't know if I say it that way, but it's like, all right, well, it gave you your options. So you decided to go to the OR.
Wait,
Is
one
this?
second. I want
Mhm.
to I want to follow that lead a little bit. It's interesting, right? Because in our current state in the United States of America with our health system, you and I say, okay, happy to operate on you because our incentives are skewed. And we're not going to talk the patient into surgery in this situation, but if they don't want an injection, we don't fight them on it. What does that look like? I honestly don't even know what that looks like in some of our colleagues for some of our colleagues overseas, and I'd be curious to hear. And in a value-based care system, what does that look like? It's interesting.
Yeah, no, absolutely. If listeners have experiences, please email us handpodcast@gmail.com. And, I think that especially in Canada, for example, where you have a socialized system and, you have queues for everything. Now, clearly, Wallant has taken those procedures out of the OR and into the office, but still there's probably a queue for that. Yeah, do you have to have tried a steroid shot? And how many patients do you think, just anecdotally, have you had that have been unhappy that they tried the steroid shot rather than going straight to surgery?
I don't know that I've had a lot that are unhappy, because it almost always works. It's just a question of for how long. And I try to be honest with my assessment. Have you had unhappy patients that have had a steroid shot?
In some, yes, occasionally, because they're like, well, I told you this wasn't going to work, and you said to try it. I said, okay. I find that, just um, the nuances of our healthcare system, those patients who tend to forego the steroid injection always come in November, December because they've met their deductible and they just want to knock it out and get it done.
No, that's right. That's right. All right, let's cut to the chase because I want to do some rapid fire of these problems. So go to the OR at the patient's request, and I couldn't argue with him. Local only, once again. Um, Opened the initial surgical site through a slightly larger incision. Um, Thankfully, full release of A1, clearly, some scarring. Um, I went and released a bit more of the PA pulley proximally. I had touched the A2 pulley, released a little bit more of that, asked him to flex and clunk clunk. When he flexed, he still triggered, and there was nothing there. Next step,
Well, I think you would have done this, but I think it's a really important point to check the EDC. So flip the hand over and make sure it's not EDC subluxation, which I don't think was the case here, but important teaching point.
thank you.
I think at this point you're looking at an FDS slip excision.
Absolutely. And what seems to have happened, not surprisingly, is just the chasm was not allowing free movement. So took out an FDS slip, immediately resolves the issue. And it's for those who haven't done that, you can do it through that proximal incision, and I did, but it's a lot. It can be a lot. You have to really flex the finger and trace the FDS up far enough to make sure you've done sufficiently, because obviously you don't want to be back for a third surgery. So that's what I did on both sides. In the OR was happy, postoperatively was happy. So hopefully that's resolved.
I think the only other thing I'd ask you, well, awesome, great result. Nice to say that, to see it and to have the patient see it. But was there a role for a tenolysis, like a traction tenolysis you would do if they were asleep?
I did a little bit, and obviously you can't do that wholeheartedly in someone who's awake. I certainly was more aggressive about pulling both tendons up into the wound, to make sure we didn't have too much scarring distally. I don't think that alone would have solved the problem if that was your question.
Okay, very good. You want to go rapid fire, but first we should thank our other sponsor, Checkpoint Surgical, who is proud to support the third annual nerve and tendon surgical skills course at The Ohio State University, which was defeated by the University of Miami on February 21st, 2026.
I like that. Designed for fellows and early career hand surgeon, this cadaver-based course focuses on upper extremity nerve and tendon repair with a hands-on interactive approach. Only 30 spots available, so register today at nervemaster.com. Exclamation point.
There you go. That course will be great. Amy Moore does a fantastic job organizing it, and her partners are incredibly skilled, and I think they bring in some guest faculty. So hopefully people will check that out.
For sure. I want to cover three additional diagnoses. Again, a little rapid fire, but talk about how we think about it. So the first is dequervains. So I'll kind of speed this along. Patient has had temporary improvement from injections, and now has a recurrence, doesn't want a second, we'll say doesn't want a second injection, would like a definitive answer. So you go to the OR for a first compartment release. Kind of how do you think about doing the surgery, hopefully the first and only time, and how do you think about managing them after surgery?
I will answer your questions, but I'll give you a couple rapid fire. How many injections is the max you will give?
Two is the max. I don't do more than two.
How many dequervains cases do you think you do relative to the number of injections you give in the office in, say, a year?
Um, 10%, maybe slightly more than that, but 20% max. I don't know the answer to that, but not many. What about you?
I probably do like two or three dequervains a year, and I give a heck of a lot of injections. It's just something you'd think is so common, but it is something with a much higher cure rate with a steroid injection as opposed to trigger, which I think is a little more variable. But anyway, this is for me, it's under local. I know some of our partners don't like doing this under local. I infiltrate probably about 10 cc's in the pre-op area. I plan out my incision, which tends to be, I like an oblique incision. And the distal aspect of the incision is just proximal to the radial styloid, probably about a 2 or 3 centimeter incision. The name of the game of the surgery is immediately after the dermis finding the superficial radial nerve, typically the dorsal branch, although sometimes you can have a volar one kind of creep up in your incision, but spreading along the course of that nerve, and then using the tips of my tenotomies to feel kind of where the roof of that first compartment is while I spread in course with the SRN, retract the SRN, find the roof, and then do my release from there.
Love it. Agree with everything you said. My two caveats are number one, I release as dorsally as possible to try to theoretically create a volar, block to tendon subluxation, which I think is the point of our conversation here. And also, of course, make sure there's no separate compartment for the EPB. There's a couple papers our previous chair, Richard Gelbman, had published that I want to say 67 to 70% of patients who go to surgery have a separate EPB compartment. Almost everyone has multiple slips of APL, interesting, but it's the separate EPB compartment which can get you. But do you try to release as dorsally as possible, and do you think that helps?
I do release as dorsally as possible. And then I will say the distal aspect of my release is basically at the radial styloid because we know that that's the distal end of the first dorsal compartment. I look for EPB muscle belly because that's how you can tell that you have the EPB and not just a slip of your APL is seeing the belly of the EPB. Because sometimes people say, well, you can just have them extend their thumb, but like, how can you really tell? Because usually when people are extending their MP joint, they're also palmally abducting, which is your APL. Um, so yeah, I go as dorsal as possible. So the reason why is that the risk is that the tendons would subluxate volarly if you release the roof a little bit too volar. And that was described by Dr. Weiland, uh, as asked of me by Dr. Peter Stern during my fellowship interview with him. Did not know the answer to that question. But I have not seen volar subluxation personally, but maybe it's because I'm so intentional with being dorsal. Has this come up for you in your many decades of hand surgery?
Well, it's interesting. A quick question for you. Before I answer yours, do you actively or passively rotate the forearm to assess tennisability? I've never done that, and I wonder why I haven't. Do you do that in the OR?
I do. I move it around.
Oh, that's good. And do you ever find that the tendons are unstable in the OR?
No, I haven't, knock on wood. But
Yeah.
again, like I said, I don't do a ton of these because just the way my practice patterns are, doesn't come up a whole lot in terms of surgery, but it's not been, I have not seen it personally.
So interesting. So I need to do that. I haven't. I just do the release and do it as dorsally as possible. I have reconstructed a couple over my career. Thankfully, none of them were my own. And I probably am a little conservative. I put them either in a really bulky thumb spike, a soft dressing, or I put them in a splint afterwards
Is this for a
for
primary or for a
a
after you
primary,
revise? Hmm.
because I'm so worried, and maybe I'm overly worried about tendon subluxation that I do that. And again, sometimes it's soft, but I give the patient the choice. If you have little kids running around, which some families do, given the incidence in new moms. So I don't know. I probably am torturing patients a little bit with immobilization afterwards to try to minimize the risk of that complication.
So how long are you're doing a bulky dressing or a plaster splint in addition to the bulky dressing?
Either one or the other based on patient preference. And then when they come back at 2 weeks, for wound checks, stitches out if I didn't put non-absorbables in, then I give them the choice of wearing a splint for an additional week or two. Um, and knock on wood, I've never had the problem, but neither have you, and you probably do a lot less.
Yeah, so I do a bulky soft dressing for 5 days, have them take it off, switch to a thumb spike, a DME brace, which they've had because they've tried it already. And if they can't find it, I just have them get it from DME in the post-op area. And activities as tolerated, tell them to take it easy. But, fortunately, has not been an issue so far.
Good, good. All right. Another straightforward diagnosis in quotes, dorsal wrist ganglions. And so we quote, all of us, I think, 95% cure rate, really whether open or arthroscopically performed. I typically do these open, transverse incision for healing. But the key is, what do you do when you take out the ganglion? You trace it down to the dorsal scapholunate ligament, and then what do you do after that?
I find this to be, I mean, a lot of what we do is dogmatic.
For
This is
sure.
this is so dogmatic, but it's what I was taught, and I can't find any evidence to refute or support it. But and it's no cost. But I guess if you weren't going to apply a Bovie pad or open a Bovie for the case, but I cauterize. But to that point, when I do mucus cysts and I do them under local, my local pack does not include any cautery because I don't use it. So I don't cauterize when I do mucus cysts. I just kind of rough it up with a rongeur. So I don't know, but to answer your question directly, I cauterize the area where the stock was emanating from. What do you do?
The same. And it's interesting. Yeah, I've had my share of recurrences. I do a fair number of ganglions. I have a young population, and we're not here to talk about all the other treatment options, maybe another episode, but my gut is when they recur, maybe there's something else going on. Maybe there's more inflammatory tissue. I don't know. I'm sure some of them are just a recurrence, but
Do you think it's more of a ligamentous laxity thing, like an EDS situation, or do you think that plays a role, or do you think if there's an actual injury?
well, I certainly check the SL interval after the excision. I do a Watson scaphoid shift test. I've written about this, early in my career. That yes, there is some ligamentous laxity typically, but I don't know. I just don't know. I think that's as good an explanation as any, and I think it's just one of those things where you do your steps carefully, completely, and don't rush it. You got to get down the ligament. You got to take it off from the ligament, and cauterizing that base or stalk if it's visible, which it usually is, I think is the appropriate thing to do and maybe the only thing we can do.
Any of the athletic trainers, MAs, therapists, residents, fellows that are in clinic with me know that I really do not like seeing ganglion cyst patients in the office. Of course, I like interacting with the patients, but in terms of a condition, it's just something I don't enjoy seeing. And maybe that word has gotten around, and I'm happy I'm not doing a ton of these. But it is not a surgery that brings me joy. It is a surgery I will do if the patient really, really wants it. I will literally try everything else before offering them surgery. But some people come in and they're like, I want it out. And there's no talking them out of it. And I say, if I don't do it, some other person's going to do it. So just go ahead and do it.
It is a good one to work with residents and fellows with because I think technically there are things that make it nice. You have to, you could spend an hour on this case if you're not direct and pushing it again, maybe a conversation for another time. But I like the need to be, really protect the associated structures and then just get it done.
Well, that's the thing is with ganglions, and this one in particular, you could spend so much time bluntly spreading and just messing around in there. But like once you get down, once you've got between your extensor tendons and you are deep, you're for a dorsal ganglion, your sensory nerves are out of the way. If you're deep in your tendon interval, everything's out of the way. And then I just tell the resident or fellow, like, stop messing around, get the knife out, just cut this thing out. Because you can push around the tissue in so many ways, and you can spend so much time trying to atraumatically do this, but by bluntly spreading more and more, creating more scar tissue, you're actually more traumatic. So just take the knife and cut it out.
100% agree. And I take out a little segment of dorsal capsule, one by one or two by two. I think it's fine. The capsule regenerates, nothing to close deep. And that's part of making it an efficient operation.
And why would you do this under the scope? Why would you torture yourself with that? Like, just get it out.
I do it on certain occasions if there's another reason to do a scope or something just doesn't seem right. So honestly, it's 5% of my dorsal ganglions, maybe less do I do arthroscopically.
All right. So quick hit post-op protocol for these.
2 weeks in a splint. Fingers are free, wrist does not move, come back, ramp up as you tolerate. What about you?
Bulky dressing. I basically tell the resident fellows set it up like you're about to put on plaster, but don't put on the plaster. Keep it on for 2 weeks, and then just cock up wrist brace from DME as needed. Activities as tolerated. Range of motion. I teach them some exercises. Typically, don't need to go to therapy. Tell them push-ups are going to be hard.
Yeah. Another source of, this is dogma for sure, this splinting. Volar ganglions, the same, but just a little more. I think that, we quote a 20% recurrence rate. I quote a 20% recurrence rate for volar ganglion. Obviously, you got to deal with the radial artery, which sometimes can be a bear. And just tracing it down to the joint is trickier and just requires a little more patience and technical dissection. Because if you get sloppy and you don't get down to the wrist joint, I think that's when recurrences are more likely to happen.
Yeah, this is a much more engaging case, put it that way. Um, and I get some excitement out of dissecting out the radial artery with the resident or fellow. It's good technical training for them. It's good for me to see that they know how to do that. And then sometimes the textbook thing is that sometimes you have to leave some of the cysts along the radial artery because theoretically that could increase your chances of recurrence. But if you get at the stalk, then you're fine. How often are you leaving part of the cyst with the artery?
Very rarely. I will not be shy in saying that I have had to repair the radial artery in this situation when the stalk is really against the wall and you try to take it out, you get a small tear and you put a stitch in. It's not a big deal. But I think you're right. If you get the stalk completely out and you leave a little residual wall adjacent to the radial artery, there is no problem with that at all.
You let the tourniquet down before you close?
It's one of the surgeries where I do. Yes.
Yes, if Dr. I tell the residents and fellows, if Dr. Goldfarb is letting the tourniquet down before something, you damn sure I am too. So,
Yes.
you want to
Um,
finish with one more?
your favorite surgery ever, carpal tunnel. Yes. So what goes wrong in carpal tunnel release?
I think that there could be a few things. I think that falling into Guillaume's canal is probably the earliest thing. Technically, you could have an injury to the palmar cutaneous branch during your approach, although that's probably unlikely if you place your incision appropriately. But if you do place your incision a little more ulnar, you can fall into Guillaume's canal. And typically, that's if somebody is not holding the palm flat for you, or you are not holding it flat for somebody else, because then just a natural tendency to pronate the forearm and the palm will land you right in Guillaume's canal. So if you're seeing a lot of fat, reassess, put the hand flat, and then really the key is finding, once you see superficial palmar fascia, you're back home. And you can use that to your advantage if you're doing combined carpal guion, right? So you know where to go based on that. But so for an isolated, just only primary carpal tunnel release, I think the biggest thing is not falling into guions.
I think that's right. And obviously, a complete release, making sure you're completely released distally and proximally. And that, to me, the distal assurance is important. I am struck by the fact when I think about surgeries and the duration of the surgery, I don't think any surgery I do has a bigger percentage delta as far as time. And what I mean by that is when you have the right carpal tunnel surgery, 3 minutes, 4 minutes, I don't know, really fast. And if you have a more challenging carpal tunnel, it's still fast, but it can be double that easily, or it could be 10 minutes. Just sometimes it's a lot more, whether it's patient has fatty tissue or it's any comments on that, or am I being dramatic?
No, I think the ideal is the one song carpal tunnel release. So if the it works out for the gods and a song is starting when the carpal tunnel release is beginning, I keep track of that song. And if they get the case done in time, I tell the resident fellow like that was a one song carpal tunnel release. Well done. But I think that yes, it can be variable based on if you initially get kind of veered ulnar, that can derail your case by at least 60 seconds, which, again, is not a lot of time. But in a case where it could be 4 minutes, like that's, it could be an area where that delta comes from. Distally, I think that's in the literature, the incomplete release is distal. What I've found in practice is that's usually proximal when I'm going back and revising others. But distal release, just a teaching point, we always want to see that sentinel fat that's surrounding the superficial palmar arch because it means that you've got a couple more millimeters left of ligament to release. Once you see that fat, you release a little more, you should be good. And then proximally, I think where people can get into trouble, and fortunately has not happened to me, but you can cut either the ulnar bundle or the median nerve or the palmar cutaneous branch if you're too aggressive and with your release proximally.
Totally agree. It's interesting how I set things up. I'm usually the one who goes proximally, um, just for visualization purposes and safety purposes. I think I can see better helping my helper going distally. Is that how you do it as well?
Yeah, it's honestly it's because the way everybody here was doing it is that the attending would go proximally and the trainee would go distally. Gets a little tricky when you have a left-handed trainee, but
Yep.
we make it work. And then when I said aggressively with the proximal release, I mean the curve of the tenotomy is going in the wrong direction. So you really got to directly visualize. One thing that I've moved to now is when we go proximal, before I put the deep end of the ragnel into the apex of the proximal apex of the incision, I have the trainee put the small end first, and I just bluntly spread in that very superficial fascia, release that, because then you can get that ragnel, the deeper end into that apex, much deeper, and you have a straight shot. And it also frees up some of that tissue that could cause you to get into trouble if your tenotomies catch on it as you're doing your release.
Well said. Tom Kefauver in Cincinnati taught us to create a little box
Hmm.
with the proximal apex and then the two on the side and improves your visualization. And we'll close with what's your postoperative management of carpal tunnels?
So what's worked for me for the last 18 months has been a foro monocrol on a P3 needle, monocrol P3. That pairing has been really nice to me. Buried closure, so a deep dermal, which is a little bit tricky to do in the palm at times. Dermal bond. Dressings off at 3 days. So light dressings, just Weberil, Coban, light, fingers and thumb free, wrist largely free. And the dressing comes off at 3 days. Activities is tolerated. How about you?
Yeah, nylon, 2 to 3 nylon sutures, dressing off at 3 days, shower, no soaking, advances tolerated. And some people, as you know, fly through this, and some people have more pain and just take a little longer. But everyone's typing, day one. And if you do bilaterals, as we have discussed many times, people do fine as long as they're motivated to do bilaterals.
Yeah, I don't talk people into it. I offer it. I tell them about the paper that you guys wrote before I got here about the experience with bilateral carpal tunnel. Anecdotally, I've kind of shifted to if you live alone, do one at a time. Because sometimes they're if they do both and they live alone, what I've noticed is that if they have a hard time with certain things around the house, they get frustrated and then they, lack of a better term, let you know about it. So yeah, typically we'll tell them what to expect in terms of heavy pots and pans, heavy doors. And we do give them, I give them gloves to wear in the bathroom for those first 3 days and tell them that sometimes you got to cinch the bottom of the glove closed with a little plastic wrap or a bag or something like that just to keep the dressing dry.
Love it. Love it. This was fun. I like this kind of episode.
Good. Well, so listeners, if you have things that you want rapid fire from Professor Goldfarb, please email us handpodcast@gmail.com and let us know what you want us to talk about. We can always squeeze some of these in, just even if we have another topic to discuss.
Absolutely. Have a good day. Stay warm.
All right. Good luck with the shoveling.
Thank you.